which is going to cover, I believe, an enormously important issue. I want to thank Ranking Member Mike Enzi for his work. He and I have worked together on a number of issues over the years, and I look forward to a productive working relationship. Vermont is a rural state. I know something about rural problems. His state is a lot more rural, so we will see how we can go forward together. In our country today, now before I begin that, let me thank all of our panelists for being here. We have a great set of panelists from all over the country, and we very much appreciate them being here. And we thank them for the work they do every day, providing health care and doing research. In our country today, I think as many people know, we spend almost twice as much as do the people of any other country per capita on health care. That's about 18% of our GDP, and yet our health care outcomes in terms of life expectancy, infant mortality, and disease prevention are not particularly good in terms of international comparisons. And one of the reasons for that is that we have a major crisis regarding primary health care access, which results in lower quality health care for our people and greater expenditures. Lower quality health care, and yet we end up, because of the crisis in primary health care, spending substantially more than we should. Today, 57 million people in the United States, 1 in 5 Americans, cannot see a doctor when they need to. Lack of access to a primary care provider is a national problem, but those who are most impacted are people who are low income, minorities, seniors, and people who live in rural communities, whether it's Vermont or Wyoming. As we've seen time and time again with dental care, mental health, and other health care issues, the groups that need health care the most are the least likely to receive it. The good news is that just 11 months from now, we will be providing health insurance to 30 million more Americans through the Affordable Care Act. The bad news is that we don't know how we are going to be providing primary health care to those Americans who now will have health insurance. Let me just rattle off some statistics that I think should be of concern to the Congress and, in fact, to all Americans. Not widely known, but maybe Dr. Wilper will talk about this when he testifies, approximately 45,000 people every single year die in the United States of America because they do not have health insurance and they do not get to a doctor on time. 45,000 Americans. According to the Health Resources and Service Administration, we need 16,000 primary care practitioners to meet the need that exists today. With a ratio of 1 provider to 2,000 patients, over 52,000 primary care physicians will be needed by 2025. In 2011, about 17,000 doctors graduated from American medical schools, despite the fact that over half of patient visits are for primary care. Only 7% of the nation's medical school graduates now choose a primary care career. 7%. Nearly all of the growth in the number of doctors per capita over the last several decades has been due to a rise in the number of specialists. Between 1965 and 1992, the primary care physician to population ratio grew by only 14%, while the specialist to population ratio exploded by 120%. The average primary care physician in the United States is 47 years of age, and 1/4 are near retirement. In 2012, it took about 45 days for new patients to see a family doctor, up from 29 days in 2010. In other words, even if you can find a family provider, it often takes a lot longer than it should to see him or her. Only 29% of U.S. primary care practices provide access to care on evenings, weekends, or holidays, as compared to 95% of physicians in the United Kingdom. In other words, our culture is don't get sick on Saturday, Sunday, or night. 9 to 5 works pretty good. Half of emergency room patients would have gone to a primary care provider if they had been able to get an appointment at the time one was needed. In other words, we are wasting billions of dollars because people end up in the emergency room for non-emergent care because they can't find a primary health care physician. In my view, and I think the view of all of the experts who have studied the issue, primary care is intended to be and should be the foundation of the U.S. healthcare system. In 2008, Americans made almost 1 billion office visits to the doctor. 50% of those visits were to primary care doctors, half. According to virtually every study done on this issue, access to primary health care results in better health outcomes, reduced health disparities, and lower spending by not only reducing emergency room, but when you get people to the doctor when they should, they don't get sicker than they otherwise would be and end up in the hospital at great cost. The problem we are discussing is clearly a national problem existing in 50 states in the country, but it is even worse for particular geographic regions. The ratio of primary care doctors in urban areas is 100 per 100,000 people. Double the ratio in rural communities where it is 46 per 100,000. So urban communities clearly have problems. Rural communities have even greater problems. 65% of primary health care professional shortage areas are in rural counties. My own state, we do much better than the rest of the country in terms of primary health care providers per 100,000. And yet I can tell you that in the state of Vermont, people often have a difficulty getting to the primary care provider they need. Although 20% of Americans live in rural areas, only 9% of physicians practice there. One of the significant differences between the U.S. healthcare system and the healthcare systems of other highly developed countries, which could significantly explain why we spend so much more than other countries around the world, is the ratio of primary care physicians to specialists. In the United States, roughly speaking, 70% of our practitioners are specialists, 30% are primary health care providers. Around the rest of the world, that number is exactly the opposite. About 70% of their practitioners are primary health care providers, 30% are specialists. What can Congress do to address this very serious issue? Let me just rattle off a few points and give the mic over to Senator Enzi. First and foremost, clearly, we must address the issue of primary care reimbursement rates. Specialists earn as much for their lifetime of practice, as much as $2.8 million more than primary care providers. So if you're going into medicine, if you're a specialist, you can earn throughout your lifetime almost $3 million more than a primary care practitioner. Radiologists and gastroenterologists, for example, have incomes more than twice that of family physicians. The system for setting physician reimbursement in this country is largely determined by the 31 physicians who sit on the American Medical Association Committee called the Relative Value Scale Update Committee, generally called RUC. The RUC, whose payment recommendations are accepted by the Centers for Medicare and Medicaid Services over 90% of the time and are adopted by many private insurers, is dominated by specialists. So specialists sitting on the committee determine reimbursement rates. We have to look at that issue. Medicare has promoted the growth of residencies in specialty fields rather than primary health care by providing significant sums, $10 billion each year, to teaching hospitals without requiring any emphasis on training primary care doctors. Serious issue. Thirdly, unlike other nations which provide significant financial support for medical school education, we by and large do not do this in this country. And the result is the median debt for medical students upon graduation is more than $160,000, and almost a third of medical school graduates leave school more than $200,000 in debt. Now, if you're leaving school $200,000 in debt, what are you going to do? You're going to try to figure out how I make as much money as possible to deal with that debt. And you're going to gravitate toward those fields which pay you higher incomes. So, if we're going to attract young people into primary health care, we must make that profession more financially attractive. In other words, we must address the issue of how reimbursement rates are set for Medicare, which impacts reimbursement rates for all physicians. Second of all, in recent years, and I have worked on this issue, other members have worked on this issue, we have greatly expanded community health centers around the country. And community health centers provide very good quality, cost-effective health care. We need to do more than that. We've made progress. We need to make more progress. We need, in recent years, we have significantly increased funding for the National Health Service Corps, which says to somebody that if you're graduating medical school $200,000 in debt, we are going to help you address that debt. We'll help you pay it off if you practice in underserved areas. It is working. It has worked. We've made progress. We need to make more progress in that. Teaching health centers. Studies have shown that residents trained in community health centers or rural communities are more likely than those trained in other settings to make a career practicing in underserved or rural areas. The THC program was the only new investment in graduate medical education in the Affordable Care Act, and the 5-year funding was only $230 million. We've got to expand that concept. We've also got to take a hard look at the role of allied health providers, nurse practitioners, and others. How do we better utilize those people in the provision of health care? So we've got a very, very serious problem. The lives of thousands of people depend upon what we do. And I am very excited about the wonderful panelists that we have at this hearing. And now I'd like to hear from Senator Enzi, who has done so much work in this area.
Thank you, Mr. Chairman. Thank you for holding this hearing, and I'm glad to be joining you for my first hearing as ranking member of this subcommittee, and I look forward to working with you. I'd also like to thank the witnesses for taking time out of their schedules to be with us. I particularly like to welcome Toni Decklever from Cheyenne. She's worked with me and my staff on healthcare workforce issues for a number of years, and I appreciate that she made the long trip across the country to be here. It's a pleasure to welcome all the witnesses to our hearing. The issue of improving access to primary care services and aligning our health care workforce is one that's important to all of us, but one that's especially significant given the obstacles that people face in Wyoming. Nearly the entire state is considered a frontier or rural county. 47% of the population lives in a county with fewer than 6 residents per square mile. According to the Wyoming Department of Health, approximately 200,000 residents live in health professional shortage areas with inadequate access to primary or dental care. There are serious access challenges in Wyoming that require creative solutions to resolve. We have one hospital that's served by a physician that every time we lose that physician, the hospital closes. To that end, the state's developed a number of programs that are tailored to meet the specific needs of a frontier state. Where distance presents the biggest barrier to accessing a doctor, we say that we have miles and miles of miles and miles. And recruiting healthcare professionals to live and work there is an ongoing challenge. The Wyoming Department of Health operates its own health professional loan repayment program, along with a physician recruitment grant program. These programs work to reduce the high cost of health professional graduate and training programs, which is often a deterrent to working in primary care or other lower income medical fields. The Wyoming Health Resources Network represents another innovative approach to improving access and reducing primary care workforce shortages. This collaborative arrangement between the major medical and health professional societies, the University of Wyoming, and other key partners maintains an extensive database on Wyoming healthcare facilities and their need for professionals. Sharing information more effectively allows for better allocation of resources and manpower at a time when the fiscal climate limits our ability to spend money on the problem. There's more that can be done to better align federal programs to meet the needs of rural and frontier states. The criteria that determine eligibility for federal funds to support rural health programs are based on factors that make it difficult to prove the needs of the underserved in rural and frontier areas. For example, one provider per 3,500 people in New York City is entirely different than 3,500 people living in Fremont or Campbell County. In addition, we need to think more creatively about how to use technology services to improve telemedicine capabilities so that where a person lives has less impact on the level of care they're able to receive. The advancement of more powerful wireless technology has substantial potential to remotely link individuals across the country to deliver health care in more accessible settings. We've had quite a bit of success with that with some of the veterans outreach clinics, where they use telemedicine extensively, with nurse practitioners being in charge of handling the equipment and a doctor on the other end of the telemedicine. I hope this hearing will make it clear that we need to think more creatively and figure out ways in which all Americans can better access primary care services and ways to ensure health care professionals are employed where they're most needed. I look forward to hearing from our witnesses on what needs to be done to solve these problems at the federal, state, and local level. Again, I want to thank the witnesses for their participation. I want to thank the chairman for his great list of suggestions on things that need to be done. And I'm sure that we have the capability to come up with some solutions through this committee.
Senator Enzi, thank you. Thank you very much. Senators will get 5 minutes. Senator Warren was here first. Senator Warren? Yes.
No, I just want to thank you very much for holding this hearing. Mr. Chairman, I am very interested in the question about how we equalize access for all of our citizens, and particularly interested in the question about how we make the right investments to lower the overall cost of health care. I think the chairman said it best when he said what we're looking for is better outcomes at lower costs, and that is the peculiar role that the federal government can make if it makes the right upfront investment. So I'm looking forward to hearing from each of the panelists. I also want to thank the ranking member. I think the comments about access and the reminder that it's very different in a large city than it is from a very rural area are comments that are well taken and one for us to remember carefully. And also the reminder that that can have very different consequences, even in a state like Massachusetts, where obviously we have very extensive health care services in some areas, but it still leaves us with parts of the people, the population in Massachusetts with difficulties in accessing care. Sometimes distance is less the challenge, but costs can remain the challenge, and transportation, even within close areas, can be a serious challenge. So I appreciate the reminder of the diversity of issues that we face in making sure that all of our citizens have good access. Thank you, Mr. Chairman.
Thank you very much, Senator Warren. Senator Baldwin.
Thank you, Mr. Chairman. I will not use the allotted time in its entirety and apologize to the panel that I'm going to have to sneak out to attend another committee meeting and return, I hope, for the Q&A. But I appreciate, Mr. Chairman, your focus on this broad but very critical issue that has so much relevance in seeing through the implementation of the Affordable Care Act. I represent a state that has urban concentrations as well as perhaps not as large spaces of rural areas, but certainly has the array of challenges that are the subject of this hearing, and I appreciate the attention that's going to be focused on it. One of the things that I hope that we'll hear some elaboration on, aside from issues that compensation plays in this, is the questions of lifestyle for primary care practitioners, things like the differences between the amount of time that somebody might be on call as a specialist versus a primary care physician. As we look at larger payment reforms, how the flexibility in their practice of being able to spend the adequate time with a patient, for example, with multiple chronic conditions that is necessary versus seeing folks in 15-minute increments, et cetera. What impact will those policy changes have on the number of primary care practitioners in this country? But anyways, Mr. Chairman, thank you for focusing attention on this issue, and I hope to return to hear more from the witnesses and ask my questions.
Thank you very much. Senator Franken.
Thank you, Mr. Chairman, for this incredibly important hearing. We have 30 million more Americans, we hope, if Medicaid is adopted by the states, the expansion of Medicaid, leaving some people still uninsured. Read the testimonies last night, and it is very clear that when you insure people, their health care outcomes are better, and it actually costs us money when people aren't insured. And so what we're doing, and it's so clear, and you know, sometimes you hear, well, we have health care in this country, you can just go to the emergency room. Well, that's the most expensive health care, and it doesn't mean that you get treated after the emergency room. It doesn't mean that you get what you need to treat a chronic condition. All of your testimonies put the lie to that, and I appreciate that. In Minnesota, we do health care relative to the rest of the nation extremely well. HHS has rated us #1 in high-value care and outcomes divided by cost. And we, like Wisconsin, have kind of a combination of urban centers and not the miles and miles of miles and miles, but we have miles and miles. That the ranking member, whom I would like to welcome to this subcommittee, and I'm looking forward to is partnering on this, and I admire his work on rural health, which is so important in my state because there are people that are underserved. One of the things that the chairman talked about was the student loans that, you know, graduating from medical school with a typical loan, a debt of $160,000, sometimes more. And then talking about the tendency for doctors then who've just graduated to say, how am I going to make this money? And we have, you know, MedPAC, and this is an issue that you talk about in your testimony. In our country, we pay specialists on a ratio more than primary care physicians than they do in other countries that do their health care very successfully and cheaper and less expensively than we do. One of the things about student loans, to me, there's nothing good about the high cost of college and of graduate school in my mind, except that the only probably good thing is that it creates some tool for us to motivate people to go into the things that we need. And the one question that I would like the panel to think about, and I know you're going to give your testimony and we're going to do the questions, so, is what is the return on investment if we say to doctors graduating medical school, we're doing some forgiveness, we're doing especially forgiveness for being a primary care physician in a rural area or an underserved urban area, but what would be the return on investment if we really, really encourage by loan forgiveness doctors to go into primary care? In other words, what is the calculus there? What's the equation? If we say, my goodness, it is such a benefit to society and such a cost benefit to have a higher ratio of primary care physicians. that if we said for anybody who goes into primary care medicine, we will, it's $100,000 right there, boom. Is there a cost? What's the cost benefit there? It's good to see you, Dr. Reinhardt. Dr. Reinhardt and I have talked a number of times. He is a healthcare economist, so maybe that's something you can mull over. But anyway, I thank you, Mr. Chairman, for this unbelievably important hearing. Thank you.
Thank you, Senator Franken. Senator Murphy.
Thank you very much, Mr. Chairman. I'm excited to be a member of this committee and excited to be here with a fantastic panel. And so I'll get out of the way so that you can provide us with your testimony. Let me just say this. Having chaired the Health Committee in the state legislature in Connecticut for years, we grappled with this problem year after year. And I remember specifically one meeting that I had with about maybe 15 or 20 medical students at the University of Connecticut. And at some point in the meeting, we were, I think, talking about the Affordable Care Act and how it could help medical students. We were talking a lot about this issue of the high level of indebtedness. And I asked them how many of you are considering, not committed to, but considering going into primary care. And of the 15 students around the table, one of them raised their hand. Only one was even considering it. And so we started to examine this question as to why they didn't even have it on their mind. And certainly the dollars were the first thing that they mentioned. All of them are going to have extreme levels of indebtedness, even coming out of a state university, and they just really couldn't figure out how they were going to make that work with the salary that they were going to make as a primary care physician. But as you started to tease a deeper answer out from each one of them, the second thing that came up was prestige. That they didn't feel that there was real prestige any longer in being a primary care physician, that if you really wanted to practice cutting-edge medicine, that you had to go into the specialties. And they all had an ego to them that wanted to put them on the front lines of new medicine. And I hope that that's part of our hearing as well today, is how do we put the practice of medicine back into primary care? How do we allow them to be more than just gatekeepers? And I think that there's a perfect opportunity as we start to roll out these new delivery system models, as we envision a world where accountable care organizations and interconnected multi-specialty practices are the rule rather than the exception. Well, we invest in things like medical home models. You allow for primary care physicians to once again control a lot more medicine than they used to control. The prestige comes back, maybe not so much in the medicine that they're practicing, but in the control they have over the healthcare system writ large. And so I think that as we build a new delivery system, it's an opportunity not just to address what I think is still the most critical question, which is how do they just make their family's budget work if they decide to go into primary care, but how do they get to feel really good about the medicine that they're practicing and the value that they're adding to their profession, because that's been lost as well over the years as the prestige has moved to the specialists rather than the primary care doctors. And I imagine we'll examine that topic today as well. Thank you very much, Mr. Chairman.
Thank you, Senator Murphy. Senator Casey.
Mr. Chairman, I'll submit a statement for the record. Just want to thank you for calling this hearing. It's a critically important issue, and we're grateful that you did the work. I guess the one quick comment I'd make is when we go to the attending physician as members of Congress, we have a doctor available to us here in the Capitol, and that doctor, in a sense, is our quarterback who can make determinations about our health and can refer us to all kinds of specialists and others that help us. And we hope that one of the conclusions that results, or one of the goals here, I guess is a better way to say it, of all this work in this hearing and otherwise, is that everyone has that primary care doctor, that quarterback in their life who can treat them but also get them access to specialists and the best care. Thanks.
Senator Casey. Senator Hagan.
Thank you much, Mr. Chairman and Ranking Member Enzi. Thank you for holding this hearing today. I think this is a critical issue facing our country today. I know that in my state of North Carolina, we have more than 1 million people who don't have access to primary health care because of a shortage of providers. And I know that when patients can see a primary health care doctor, they frequently end up getting care, obviously. But what happens when they don't have that access? They go to the hospital, and that's where emergency care and treatment is so expensive, and it's currently helping to drive up the cost of health care. And also, if you've got a chronic disease and you can manage that disease, it's much less costly. And otherwise, they will develop into acute care episodes. I know that there are innovations going on in this area, and one of them is in North Carolina, the Blue Ridge Community Health Services, which is a community health center in the western part of our state. It received a grant just this past November under the Teaching Health Center program. In the Blue Ridge, they've served 20,000 patients last year through 70,000 encounters with 2 primary care sites, 4 school-based health centers, and 1 dental center. And they do outreach at a local domestic violence shelter. And this funding that they have given has allowed them to increase the number of residents at this facility in Hendersonville. And I think those new residents are really critical to helping with providing more primary health care physicians. Blue Ridge is one of 34 federally qualified health centers in North Carolina that do provide that high-quality, cost-effective care to so many people across our state. And I know that there's another provision that's important, and that is the Rural Physicians Pipeline Act. That was included in the Affordable Care Act. And it gives the medical schools the resources to recruit students from rural communities. So much of this primary care access is lacking in our rural communities. And if we can train physicians from those rural communities, they tend to stay in rural communities, which I think is certainly a highlight of this provision. So programs like that, I think, have a significant role to play in relieving this current primary care shortage. But I'm delighted to have this committee hearing. I look forward to hearing the testimony of all of our witnesses today. Thank you.
Thank you, Senator Hagan. Senator Whitehouse.
Thanks very much, Senator Sanders, for holding this hearing. You've drawn a big crowd, I think, because it's an important issue. We are all gearing up here in Washington for Son of Fiscal Cliff, which is going to be coming in a couple of weeks. And with that looming, we're beginning to hear the usual refrain about how important it is to cut Medicare benefits and to limit access to Medicare for seniors, and that's the responsible thing to do to save money, which of course is a preposterous and ill-informed idea, particularly in the context of a healthcare system that is 100 times more expensive than it was in 1960. And if you look at the graph, it's an accelerating curve of upward cost. And when you look at a $2.7 trillion annual expenditure on health care, that is probably 50% higher. There's a 50% inefficiency penalty that we pay in the United States compared to all of our industrialized competitors. The worst industrialized competitor is 12% of GDP. We're at 18% of GDP. It's $800 billion a year spent unnecessarily. You look at the scope of this, you look at the accelerating, rocketing pace of the increase, and you think you're going to solve that by cutting Medicare? It's simply not right. As the CEO of Kaiser Permanente, George Halverson, said, that is an inept way of thinking about health care. He said, it's not just wrong, it's so wrong, it's almost criminal. So hearings like this that point out that there really is a problem with cost and with the delivery system in the United States, and that we really have to address that problem if we're not going to misdiagnose what we have. And once, of course, you have a misdiagnosis, you usually don't get the right cure either. So it's really important that we not throw seniors and Medicare under the bus, because we have failed to address the real problem in health care, which is wild inefficiencies and rocketing costs that aren't just in Medicare. Indeed, Medicare is probably the most efficient deliverer of health care in our health care system. But if we get this right, we don't just 40% of the savings will come back into the federal budget, but the rest will go to Kaiser, to Blue Cross, to United, to businesses and families all across the country. So we've got a real fight on our hands to try to make sure we steer this in the right direction, and I hope this hearing helps make sure we make the right choice.
Senator Whitehouse, thank you very much. I want to remind members of the Senate and viewers on C-SPAN that the report that we have done, Primary Care Access is available at my website, sanders.senate.gov. Okay, you panelists have been extremely patient, but the good news is that what you've seen today is there is an enormous amount of interest in this issue. So we're delighted that you're here, and we thank you again for the work that you do. Let's begin with Dr. Fitzhugh Mullen. Dr. Mullen is the Murdoch Head Professor of Medicine and Health Policy at the George Washington University School of Public Health and Professor of Pediatrics at the George Washington University School of Medicine. Dr. Mullen, thanks so much for being with us.
Thank you, Chairman Sanders and Senator Enzi and colleagues. A great privilege to be here as a primary care physician, a pediatrician who was in the first class of the National Health Service Corps in 1972, subsequently ran the National Health Service Corps. It is not only a privilege, but an astounding development in history to hear a committee of the U.S. Senate speak with such clarity about the often orphan issues of primary care and service delivery in poor, rural, and underserved communities. So if I can get over my days, I will try to be cogent. But thank you so much for convening and for the thought that's gone into this. I'm going to run through, Chairman Sanders, you gave my talk. I was supposed to be the expert. You are clearly the expert, so I will stint on some of the things that I was going to bring up, but try to focus on the issues of education and system building around primary care. The demand clearly is in front of us, the aging of the population, the advent of the Affordable Care Act, and the terrific entitlement that it provides. But that does present us with a challenge. Just a few demographics. We have about 280 physicians per 100,000 in the United States, which puts us in the middle, roughly, of the developed world. UK and Canada have less. Germany and France, for instance, have more. But we're roughly in the middle. We have about 800,000 physicians, but additionally, we have 190,000 nurse practitioners, physician assistants, and certified nurse midwives. So we have almost a 25% add-on of providers that didn't exist 30 or 40 years ago. And a point on that, important to remember, when our workforce was lean, and talking in the 60s and 70s, we were very short. And everybody, including the U.S. Congress, agreed and began a variety of programs that have lived on very powerfully today. Among those, excuse me, were the development of the nurse practitioner and the physician assistant, who didn't exist before, and the National Health Service Corps. Excuse me. So lean is not necessarily bad in terms of how we function if we want a more efficient system. There are systems that are used to the payments that they currently get, and they're not going to change until there is a real sense of need, and we're at that point. So while I'm not for holding where we are now, I think we need to think about the advantages, perhaps, and the creativity that can come from this period. In terms of the primary care challenge, I look at it in two ways. One is within the factory, the medical school, the teaching hospital, and the other is in the market. And clearly we've had eloquent testimony as to the pay parity gap that exists. In simple general terms, a specialist will make twice what a generalist makes. A generalist being your pediatrician, family doc, general internist, and other disciplines that are generalist in nature and poorly paid. That is a huge problem, and while education and training is very important, what I do and believe in, you can do the best education and training, and if you put them out in the market with those kind of incentives, you'll get what we're getting now. We've got to deal with that. But speaking on the educational side, the challenges are both at the medical school level and the residency level. As you know, this prolonged adolescence we call residency is very important and also very influential in the nature of the type of physician and the location of the physician that comes out of the education pipeline. There is in medical schools a culture that is heavily, at this point in time, specially focused. A natural dominance of the more research-oriented and subspecialty sciences, which are well represented for good reasons at medical school. But the primary care culture is often put in the back of the bus. And you will not find a primary care physician who hasn't been told at some point in their training career by a professor, you're too intelligent, you're too smart to go into primary care. That culture is toxic. and it's out there, and we need to worry about it. The young doctor today is, as suggested, drawn to lifestyle specialties. This is a problem, too, with limited hours, clear and rather refined knowledge requirements, and a predictable life. One can understand those draws, but we need to work on that. And then finally, you have the sense of social purpose and social mission. Our medical schools have been well treated by the NIH, that provides about $17 or $18 billion a year to research in medical schools, by Medicare, which provides $10 billion a year to teaching hospitals or residency programs, $10 billion a year, about $100,000 per resident. Very, very strong influence with no requirements in terms of workforce product out the other end. And given those two pay streams, we put about $300 million into primary care, family medicine, nurse practitioners, PAs, and about $300 million into the National Health Service Corps. So you've got $27 billion on one side that is generally specially oriented, and about $600 million that is promoting primary care careers. A huge imbalance, again, not surprising, the outcome that results from that. The teaching health centers, which have been referenced, a very important innovation. It moves the paradigm out of the hospital into the community, and importantly, needs to guarantee a pay stream. We can't run a residency without predictability. That is a very, very important outcome, and it's something that needs attention. The nurse practitioner, PA, is a very important asset, as I say, almost 190,000. We need more. They're more nimble. They are more easily trained in larger numbers, and that's a very, very important feature as we look at scaling up quickly our workforce. Finally, data and planning. We have a National Healthcare Workforce Commission, finally voted in through the ACA. It has not been funded. It is not met. We need a better brain in our somewhat anencephalic system, our system without a good brain to lead it. That would be very helpful. Finally, in conclusion, we have a moral triumph in the ACA and the entitlements that it brings, but also a technical challenge. In terms of legislative issues, the made permanence of the THCs is important. The full funding and greater funding of the National Health Service Corps will be essential. Bringing the National Health Workforce Commission to life is important. And perhaps most important is Medicare GME. We need to get a handle and use that $10 billion in a more constructive pro-primary care fashion. Thank you.
Thank you very much, Dr. Mullen. In order for us to have a good, vigorous question and answer period, if people could keep their remarks to 5 or 6 minutes, that would be appreciated. Our next witness is Tess Kinning. She is the Executive Director of Bi-State Primary Care Association, whose members include the federally qualified health centers in Vermont and New Hampshire. Ms. Kinning, thanks very much for being with us.
Chairman Sanders, Ranking Member Enzi, and distinguished members of the subcommittee. My name is Tess Kinning, and I am the Executive Director of Bi-State Primary Care Association located in Montpelier, Vermont, and Concord, New Hampshire. And on behalf of the entire health center community, including more than 22 million patients nationwide and the National Association of Community Health Centers, I want to thank you for the opportunity to testify on the role of community health centers in addressing our nation's pressing primary care access needs. As the committee is aware, two important events have significantly altered the healthcare financing and delivery systems of our nation: the Patient Protection and Affordable Care Act and the Supreme Court's decision about the same. As a result of these events, it is estimated that as many as 30 million Americans will gain coverage through Medicaid and/or the health insurance exchange. Yet another 30 million will still remain uninsured. We strongly support these coverage expansions, which open the door to a broader healthcare system for many of our patients. However, we know well that coverage alone does not equate to access. It is access to regular care that makes coverage meaningful. We also believe to achieve a truly reformed health system, our nation needs sustainable solutions to increase our primary care capacity, lower and manage our healthcare costs, and assure quality outcomes. It is for this reason, in my view, that any efforts to increase access to insurance must grow and expand our primary care infrastructure. Community health centers offer a unique and proven solution to these challenges. By statute and mission, community health centers are located in medically underserved areas and serve medically underserved populations and care for everyone regardless of your ability to pay. Community health centers also are directed by patient majority boards, ensuring care is locally controlled and responsive to each individual's community's needs. It might surprise you to learn that the Community Health Center of Burlington in Burlington, Vermont, provides translation for patients from the Sudan, Bosnia, Somalia, Burundi, Tibet, Nepal, Bhutan, and Burma, to name only a few. The ability to receive care in one's native language removes a major access barrier and improves the health of these families and our communities. From my years of clinical practice as a nurse in Nepal, I am able to speak Nepali with our increasing immigrant and refugee population from Nepal and Bhutan. And I see firsthand the benefits of this type of enhanced provider-patient relationship can yield. Without access to primary care, many people, including these families, might delay seeking treatment until they are seriously ill and require hospitalization or care in the emergency room at a much higher cost to themselves and to the healthcare system. The literature backs up these real-world experiences. For example, the Journal of Rural Health article found that counties with a community health center had 25% fewer emergency room visits. Other data demonstrate the community health center saved the entire health system, including government and taxpayers, approximately $24 billion annually by keeping patients out of these costlier healthcare settings. Unfortunately, Congress, with the leadership of this, Congress, with the leadership of the subcommittee's chair, had the foresight to include mandatory funding to expand the reach of the nation's community health centers in the Affordable Care Act to ensure that the promise of coverage was met with the reality of care. We believe that seeing this plan through is essential. Unfortunately, the community health center expansion is not currently on track. A recent HRSA solicitation for no access point grants anticipates spending only $20 million of the $300 million in new fiscal year funding, fiscal 13. The administration has instead proposed spreading out the community health center growth over a much longer period of time, and we urge that the full Affordable Care Act provided increase for fiscal year 13 be immediately extended to care for 2.5 million new patients, as Congress intended. The demand for community health centers continues to outpace the growth, and more than 60 million Americans still lack access to primary care. In Vermont and New Hampshire, in the near term, all of our 19 health centers have identified needs in their areas. I would be remiss if I failed to cite another vital program that supports the goal of creating medical homes for underserved Americans, and that's the National Health Service Corps. The Corps places trained health professions in health shortage areas and remains a key partner in ensuring that community health centers can meet the demand for primary care that is looming just around the corner with the ACA implementation. Community health centers around the country are ready, they're willing, they're able to be leaders in reforming our health system, community by community, from the ground up. We appreciate your leadership and look forward to your and the committee's continued support as we work to provide meaningful health care access to all. Thank you, Mr. Chairman.
Thank you, Ms. Kinning. Senator Enzi is going to introduce our third witness.
Thank you, Mr. Chairman. It is my pleasure to introduce Ms. Toni Deklever. She's a resident of Cheyenne, which is our biggest city at 66,000 people. We have 259 towns, but we only have 14 towns where the population exceeds the elevation. She's familiar with all of those, and she currently wears several different professional hats. She's a government affairs liaison for the Wyoming Nurses Association and has visited Washington, D.C. previously to advocate for her fellow nurses. Ms. Deklever is a state director for Skills USA, helping to improve the country's workforce by recruiting and preparing individuals for careers in trade, technical, and skilled service occupations, including health occupations. Finally, she's an independent consultant who helps train individuals in CPR, first aid, medication administration, and how to become first responders. She has a Bachelor's of Science degree in nursing from the University of Northern Colorado in Greeley and is a certified EMT. She's received a number of awards for outstanding service on behalf of Wyoming's nurses and workforce development groups, and we're pleased to have her here today. And I know from my weekly trips to Wyoming that it took 13 hours in airplanes and airports for you to be able to get here. Thank you.
Ms. Deklever, thanks very much for being with us. Please.
Good morning, Chairman Sanders and Ranking Member Enzi, members of the committee. Thank you for the opportunity to testify today. As Senator Enzi stated, I do represent the Wyoming Nurses Association. I've been a registered nurse for almost 30 years, and I've worked in acute care, long-term care, education, and administration. Wyoming is the 9th largest state in the U.S. with almost 100,000 square miles of land, but our population is the smallest in the nation with just a little over 500,000 people. Wyoming's frontier and rural environment impacts our healthcare systems. Wyoming has 25 hospitals with 16 designated as critical access hospitals, 25 beds or less. There are also 2 veterans hospitals and 16 rural health clinics. Wyoming has 8 community health centers, 3 are special population health centers, and 3 are satellites of larger healthcare centers. When dealing with the expanded number of patients and the barriers to care for these patients, several components need to be considered. One is the ability for providers to be able to practice to their full scope of their education and licensure. Another is addressing the shortage of providers due to retirement and a shortage of qualified faculty to educate new providers. Others include the perception of quality of care and support funding for rural areas. With baby boomers turning 65 at the rate of 10,000 a day, there will be an increase in demand for health care in traditional acute care settings, along with expansion of non-hospital settings such as home health care and long-term care. Wyoming's Nurses Practice Act, allows advanced practice nurse practitioners to practice independently in our state. This ability helps nurses provide patients in rural areas access to primary care. Unfortunately, some federal laws and regulations often limit the nurse's ability to practice at their full scope. A quirk in Medicare law has kept APRNs from signing home health plans of care and from certifying Medicare patients for a home health benefit. In areas where access to physicians is limited, this prohibition has led to delays in home health services. Moreover, the delays in care inconvenience patients and their families and can lead to increased costs to the Medicare system. This occurs when patients are unnecessarily left in institutional settings or readmitted after discharge because they did not receive proper home care. A sufficient supply of nurses is critical in providing our nation's population with quality health now and into the future. Registered nurses and advanced practice nurses are the backbone of hospitals, community health clinics, school health programs, home health and long-term care programs, and serve patients in many roles and settings. According to the 2008 national sample of surveyed registered nurses, over 1 million of our nation's 3.1 nurses are over the age of 50, with 1/4 of these nurses over the age of 60. Much like rural populations in that of Wyoming, the provider population is aging and near retirement age. This runs counter to the increasing need of growing older population and a regional or sporadic growth of younger populations. Studies have identified the retirement of providers as one of the obstacles to providing comprehensive care. Wyoming responded to the increasing need for nurses by creating a funding stream that would assist nurses to continue their education and work as faculty at the community colleges and university. This allowed the nursing programs to increase their enrollment numbers and thus educate more registered nurses. RNs are encouraged to continue their education into the advanced practice nursing level. Wyoming has a small amount of state incentive and loan repayment money for students, but the dollar amounts do not meet the demand through each biennium. To fill this void in funding, some students are able to receive funds from Title VIII and Title VII. The perception that health care also is delivered in bigger health centers equals quality is not easily overcome. Many residents are using health services in surrounding states who could have been served in Wyoming. To address this issue, one report suggested ways to recharacterize the system by having a stable supply of primary care providers, have appropriately located tertiary centers, integrate services at the point of care, medical home concept, collaborative planning and policy implementation, effective use of pooled financial services or resources, shared responsibility for achieving goals for individual health, and organized leadership that keeps the state responsive to changing needs. Federal designations provide eligibility for federal programs like HRSA 330 funding and enhanced reimbursements to rural health clinics. Health provider shortage areas, medically underserved areas, and medically underserved populations are based on factors that make it difficult to prove the needs of the underserved in rural and frontier areas. As noted by Senator Enzi, one provider per 3,500 people in an urban setting is entirely different than 3,500 people living in a county that is almost 10,500 miles of land mass. Wyoming's economy is based primarily on energy production, coal, natural gas, oil, uranium, and even wind, making it a boom and bust economy. Many people working in the energy industry make a sufficient salary when they work, but in some cases these salaries are significant enough that it can skew the average income for families based on statewide data. Though some families do very well financially, there is still a number of people struggling to make ends meet. This income disparity can be another challenge to meeting designation guidelines. Committee members, thank you for your time and attention to this very, very important matter, and I look forward to any questions you may have.
Ms. Deklevitt, thank you so much for being with us, and thanks for your testimony. Our fourth witness is Dr. Andrew Wilper. He is the acting chief of medicine at the VA Medical Center in Boise, Idaho. Dr. Wilper is a practicing general internist. He is the associate program director for the Boise Internal Medicine Residency Program and the assistant director of the Boise VA Center of Excellence in Primary Care Education. Dr. Wilper, thanks very much for being with us.
Thank you, Chairman Sanders, Ranking Member Enzi, and members of the committee. It's a great honor to be able to testify here today. I was asked by Senator Sanders about my insight, two insights specifically. One, about the lack of health insurance in the United States and its effect on health and healthcare outcomes, and also to share my thinking on practical solutions to the primary care physician workforce shortage that we face. So to start off, there is an enormous literature that has accrued over decades demonstrating that a lack of health insurance is associated with decreased access to health care and worse health outcomes. The Institute of Medicine summarized these findings in a 6-volume series earlier this century, and the conclusions were quite clear. Subsequent work has built on this evidence, including some of my own that Senator Sanders mentioned in his opening statement, specifically a paper we published in 2009 in the American Journal of Public Health, linking lack of insurance to nearly 45,000 deaths among adults in the United States annually. The research is consistent. Health insurance leads to significant benefits and is good for your health. So gaining health insurance does not guarantee access to medical care, which is the second part of my testimony, nor does it control costs. And perhaps the singular intervention that we could make at the national level to reduce costs and improve outcomes in our country with regard to health is to bolster our primary care workforce. There's an additional massive body of literature supporting the idea that primary care improves all sorts of health outcomes and lower costs. Nevertheless, we've not seen systematic changes to alleviate the shortage of PCPs in the U.S. in decades. So I'll talk a little bit about sort of 3 policy levers that I see that this committee could consider to increase the number of physicians entering into the primary care workforce, some of which have been referred to by Professor Mullen. First, at the medical school level, this is the period of time after which people graduate from college and are in their undergraduate medical training. We could introduce additional educational debt reduction, change federal funding streams to emphasize primary care, and increase funding for the National Health Service Corps. In addition, we could direct support to community health centers to incentivize 3rd and 4th year medical students to enter into primary care careers. Second point would be the area of graduate medical education. First, Title VII funding is specifically earmarked to go toward primary care programs, and these are continuously under threat of congressional cut and have been cut dramatically in the past 10 years. So re-emphasizing that funding would be an important step. A second piece would be direct payment by Medicare to teaching hospitals to offset the expense of training physicians. As we've heard today, that nearly $10 billion is spent by the federal government to support these hospitals.